Welcome to another episode from the Veterinary Research Channel. Today, we're diving into a recent study published in Veterinary Surgery that explores a potential new surgical approach for a challenging condition in dogs, idiopathic chylothorax. This is a condition where lymphatic fluid, called chyle, leaks into the chest cavity, causing difficulty breathing and other issues. It's commonly treated with a surgery involving ligation, or tying off, of the thoracic duct, which is the main vessel that carries lymph from the abdomen to the bloodstream. Often, this surgery is combined with removing part of the pericardium, the sac around the heart, in a procedure called a subphrenic pericardiectomy. Traditionally, the thoracic duct ligation is performed via a caudal approach, usually on the right side, targeting the duct at the 8th or 9th intercostal space, which is the space between the ribs. However, a known challenge with this traditional approach is that the thoracic duct often has multiple branches at this caudal location. This branching increases the risk that some lymphatic vessels might be missed during surgery, potentially leading to the condition persisting even after the procedure. Some techniques like en-bloc ligation, where surrounding tissues are tied off along with the duct, have been developed to address this branching. But what if there was a location where the thoracic duct was simpler, perhaps with fewer branches? Previous reports hinted that cranial to the traditional site, specifically around the 4th or 5th intercostal space, the thoracic duct might be a single, left-sided structure in many dogs. This got researchers thinking, could approaching the thoracic duct from the left side at a more cranial location, like the 4th intercostal space, offer advantages? Perhaps it could simplify the ligation procedure and potentially improve outcomes by targeting a site with less complex anatomy. Also, if performing a subphrenic pericardiectomy is desired, doing so through the same incision as the thoracic duct ligation could reduce the number of surgical sites compared to the traditional approach, which often requires multiple incisions. The goal of this study was to investigate this idea. They aimed to look at the branching pattern of the thoracic duct in the cranial chest of dogs with idiopathic chylothorax using advanced imaging, and then to evaluate the feasibility and effectiveness of ligating the thoracic duct via a left-sided approach at the 4th intercostal space in canine cadavers, along with performing a unilateral subphrenic pericardiectomy through that same incision.
That's fascinating. So, they looked at both clinical cases and cadavers to see if this cranial left-sided approach was a viable option. Let's talk about what they found, starting with their review of computed tomography lymphangiograms from client-owned dogs diagnosed with idiopathic chylothorax. They looked at 13 such cases. Their review focused on the anatomy of the thoracic duct at the left 4th intercostal space. They found that at this location, situated on the left lateral surface of the esophagus, dorsal to the aorta, and caudal to the left subclavian artery, a single thoracic duct was noted in 10 out of the 13 cases, which is about 77%. In the remaining 3 cases, there were additional branches. 2 cases had 2 branches that were located medial to the aorta and ventral to the esophagus, while 1 case had 2 branches on the left lateral surface of the esophagus dorsal to the aorta, plus 1 branch medial to the aorta and 1 ventral to the trachea. This is notably different from the caudal thoracic duct anatomy they observed in the same dogs, where the main thoracic duct originated on the right side with a highly variable number of branches in the caudal mediastinum. At the level of the 9th and 10th intercostal spaces, they found a median of 3 branches and 2 branches respectively, with ranges from 1 to 4 branches. They also looked for evidence of lymphatic leakage on these scans. Leakage of lymphatic contrast was observed in 8 out of the 13 cases, or about 61%. Interestingly, in 5 out of these 8 cases, the leakage appeared to originate from the cranial mediastinum. In the other 3 leakage cases, the origin wasn't clear, but extravasated contrast was seen dorsal to the 3rd to 5th bones of the sternum. Importantly, leakage was not associated with the caudal mediastinal portion of the main thoracic duct in any of these cases. This finding of leakage originating cranially supports the idea that ligating the duct cranial to the point of leakage might be just as effective as ligating it caudally. They also noted numerous small, tortuous lymphatic vessels within the cranial mediastinum in 9 out of the 13 dogs, suggesting abnormal lymphatic anatomy in this area in dogs with idiopathic chylothorax.
Those computed tomography findings in clinical cases already provide some support for the idea that the cranial anatomy might be simpler, and that the problematic leakage is often located cranially. Moving on to the cadaveric study, they used 10 canine cadavers. After injecting a dye to visualize the lymphatic vessels, they performed a left-sided 4th intercostal thoracotomy to access the thoracic duct. What did they find regarding the branching in these cadavers, and how successful was the ligation at this site?
In the cadaver study, they also evaluated the thoracic duct anatomy directly through the surgical approach. At the fourth intercostal space, all 10 cadavers had either 1 or 2 branches. Specifically, 6 out of the 10 dogs, 60%, had a single branch at the proposed ligation site. The other 4 out of 10, 40%, had a second branch located nearby. These additional branches were easily identified due to the dye and were accessible through the same incision. They also specifically checked the right side of the esophagus and found no thoracic duct branches on the right lateral side of the esophagus in any of the 10 cadavers, either visually or on the subsequent computed tomography scans. This contrasts with the caudal mediastinum, where they observed variable branching numbers and morphology, ranging from 1 to 5 branches, with a median of 2 branches. After identifying the ducts, they ligated and sealed them using surgical clips and a sealing device. To assess the success of the ligation, they injected contrast into the caudal thoracic duct and performed a computed tomography scan to see if the contrast was stopped at the ligation site. Successful thoracic duct ligation was achieved in 9 out of the 10 specimens, a 90% success rate. Successful ligation was defined as the contrast stopping at the caudalmost clip with no contrast visible cranial to the cranialmost clip on the computed tomography scan. There was one cadaver where a small amount of contrast leaked outside the duct, but even in that case, the ligation itself appeared successful based on the contrast pattern relative to the clips.
That's a promising success rate for the ligation in the cadaver model. You mentioned they also performed a unilateral subphrenic pericardiectomy through the same incision. How did that go?
Performing the unilateral subphrenic pericardiectomy was straightforward. They were able to easily remove all the parietal pericardium ventral to the phrenic nerve down to the ventral midline in all 10 cadavers through the same left fourth intercostal incision. The median area of the pericardial defect created was about 70 square centimeters. This shows that the approach allows for both procedures to be done through a single opening, which is a potential advantage over traditional methods that may require multiple incisions.
Right, so we have the results. A single thoracic duct is common at this cranial left-sided location in clinical cases. Leakage in clinical cases appears to be cranial, and the ligation and pericardiectomy procedures were feasible and successful in most cadavers via a single incision at this site. Let's move on to the discussion section. What do the authors conclude from these findings, and what are the implications?
Based on these results, the authors confirm the feasibility of using a cranial left-sided approach for thoracic duct ligation in canine cadavers. They found that both the ligation and the unilateral subphrenic pericardiectomy could be performed easily and quickly. They emphasize that their findings support the need for further investigation of this cranial left-sided approach in actual clinical patients with idiopathic chylothorax. A key potential benefit they highlight is the possibility of decreasing the morbidity associated with surgery compared to the traditional approach, which often involves a right-sided double thoracotomy, meaning 2 incisions. A single incision at the left fourth intercostal space has the potential to reduce surgical time and anesthesia time. They reiterate that the observation of more limited branching at the fourth intercostal space compared to the traditional caudal location seen in both the clinical case review and the cadaver study is a significant finding. They believe this simpler anatomy could lead to easier access and potentially higher rates of successful postoperative resolution of the chylothorax. They also note that preoperative computed tomography lymphangiograms could be helpful in determining if this approach is suitable for an individual patient based on their specific anatomy. The fact that lymphatic leakage in clinical cases was consistently found in the cranial mediastinum, far cranial to the traditional ligation site, further supports the theoretical efficacy of ligating the thoracic duct at a more cranial location, like the left fourth intercostal space, as it is still caudal to the source of the leakage.
It sounds like a very promising alternative approach. Are there any limitations to this study that the authors discuss?
Yes, they mention several limitations. Primarily, the study was performed using cadavers. While they tried to simulate live conditions by using a ventilator, the anatomy in a living patient with idiopathic chylothorax might be different, potentially complicated by conditions like pleuritis, which could make visualization and dissection more challenging. Also, the cadavers had unknown medical histories, and none had overt lymphatic disease. Another challenge with the cadaver study specifically was obtaining ideal imaging. In several cadavers, contrast leaked from the injection site, which the authors believe was due to damage during catheter placement rather than underlying disease. But it prevented those cadavers from being included in the final analysis of ligation success. A significant limitation when using cadavers is the inability to assess the long-term effectiveness of the procedure in resolving chylothorax. They note that with caudal thoracic duct ligation, collateral lymphatic vessels can form over time, bypassing the ligation site. It's currently unknown if similar collateralization would occur after cranial ligation or if it would impact the treatment's efficacy in clinical patients.
Those are important points to consider. Despite the limitations, the findings seem compelling regarding the feasibility and the anatomical advantages of this cranial left-sided approach. What is the overall conclusion, and what's next?
The authors conclude that the left-sided approach to thoracic duct ligation at the fourth intercostal space, combined with unilateral subphrenic pericardiectomy, was successfully performed in 9 out of 10 canine cadavers. They also found that thoracic duct ligation at this location appeared feasible in a retrospective review of computed tomography lymphangiograms from 10 out of 13 clinical cases. The key anatomical advantage they found is that thoracic duct branching at this cranial site was limited compared to the number of branches typically found at the standard caudal ligation site. They believe this simpler structure has the potential to result in a more effective ligation. Beyond reducing surgical time and morbidity compared to the traditional double thoracotomy, this approach could offer these benefits regardless of whether pericardiectomy is performed. Given these positive findings, they strongly recommend further study evaluating this left fourth intercostal approach to thoracic duct ligation in purpose-bred dogs and, most importantly, in canine patients actually suffering from idiopathic chylothorax. They also suggest that investigating a thoracoscopic or minimally invasive approach via this cranial left-sided window is warranted.
Thank you for listening to the Veterinary Research Channel. A link for the reference paper is in the video description. Remember to test your knowledge by answering the questions in the description, and as always, keep those minds inspired, hearts light, and tails wagging.